So, I'm happy to see that you have decided to join the W&H supported webinar on the theme Aerosol in Prophylaxis, a danger for the dental team. Let me shortly introduce myself. My name is Georg Gaßmann. I'm a periodontist and the head of the Bachelor Study Program, Dental Hygiene and Prevention Management at the European University of Applied Sciences here in Cologne. I'm an IADR member and a DG Paro specialist, and the DG Paro is the scientific association here in Germany for periodontology. In the next step, I would like to shortly introduce my team. This is the dental hygienist Julia Haas. She studied here at our University of Applied Sciences. And the next colleague is Professor Dr. Julia Blanc. She is an oral surgeon and she's also member of the DG Paro and a specialist in periodontology. Then we have Professor Dr. Peter Hahner. He is Master of Science in Periodontology and also a DG Paro specialist. Last but not least, there is Dr. Markus Fussenegger. He is a dentist and prosthodontist and a CMD specialist and a psychological consultant on top. So this was the situation before Corona, and you can see me here with Julia Haas, our dental hygienist, and everything seems to be quite easy. And if we look at this situation shortly in a dental practice where I did some implant surgery, you can see that the personal protection equipment looks a little bit more sophisticated. So the questions that we are going to ask is: what are sources of infection during dental treatment? Which instruments cause aerosol and which preventive measures can be taken when handling aerosols? Which alternative treatment options such as hand instrumentation and rotary polishing are favorable? What is the new normal in the dental practices after or even while we are in the Corona situation? Answering these questions, we are going to line up some definitions, and we are looking for some infection sources, and we look for the causative microbes within the aerosol, and we are looking at aerosol creating treatment procedures, and we are going to ask ourselves what preventive procedure can we deal with when it's about aerosol. And then we look at the aerosol alternatives of aerosol creating procedures and the actual recommendations that finally we may get into the discussion. So concerning the definition, first of all, we are talking, of course, about SARS-CoV-2. This is the abbreviation for Severe Acute Respiratory Syndrome Coronavirus 2, and it is a very infectious novel coronavirus. That's why it in the beginning was called 2019 nCoV. And this is the animal that has transmitted the virus to the humans. This is the reason why we are talking about a zoonotic virus. And this animal is the horseshoe bat, also called Rhinolophus sinicus, and it lives in caves in China. And this is the virus that has mutated to become SARS-CoV-2. And the illness that is derived from the infection with this virus is COVID-19, which again is an abbreviation for coronavirus infection disease caused by SARS-CoV-2. The transmission ways are mainly direct contact and droplet transmission, including aerosol. What is an aerosol? Aerosol is a suspension of heterogeneous mixture of fluid and solid particles with a diameter of less than 50 micrometers, and it may contain viable and dead microorganisms with a gaseous medium. Spatter is differentiated and it is defined as a mixture of air, water and solid particles, and a particle size in this case is larger than 50 micrometers up to millimeters. It's therefore perceptible with the naked eye. Both media may contain infectious microbes, and thus there is no differentiation in daily practice. When it comes to bioaerosol, this is meant when droplets are filled with viable organisms. So this is what we are mainly talking about in this presentation. And there is the possibility of aerosol transmission when exposed to high concentration aerosol for a long time in a relatively closed environment. Aerosol is not something new, it has always been around, and we create it whenever we breathe or when we speak, and it is even more around the louder we speak or even sing. Or if we got inflamed within our airways, because then our tissues become more moistured. How does the virus get into the cell? The virus gets into the cell using the spike protein that gets attached to the ACE2 receptor, and this ACE2 receptor is the angiotensin converting enzyme receptor. And like this, the cell makes an involvement and the virus can get into the cell, so that after entering the cell, the membrane will open and the RNA will get into the direction of the nucleus, so that here the replication can take place, and the proteins that are needed to reassemble a new virus, they are produced at the ribosomes, and then in a self-assembling process in the Golgi apparatus, the virus will be later on released via exocytosis and can then infect further cells. The cell itself stays alive, but it does not function anymore because it is just now reproducing the virus. Here are some quick facts from last weekend. We had 7,600,728 infected people, and totally critical were 50,913 people, and total deceased were 423,901, and total active were at that time 3,375,400, and total recovered were 3,600,038,147. So which cells may be infected by SARS-CoV-2, the angiotensin converting enzyme 2 receptor interaction? First of all, of course, there are the pulmonary cells, but also extrapulmonary cells. And these extrapulmonary cells are primarily cardiac cells, the renal cells, the intestinal cells, and the endothelial cells causing systemic vasculitis, thromboembolism, disseminated intravascular coagulation, and neuronal cells, which are the reason for the lack of tasting and smelling sense. So this is really a pandemic situation, as we can see on this map. The darker blue the countries are painted, the more infected people and deceased people have been counted in these countries. The reason why there are still some white countries is not that they have no COVID, but they do not count. So do we have to wait for vaccination before continuing prophylaxis? Let's get back to the questions that we have already asked in the beginning. What are sources of infection during dental treatment? First of all, there is the water cooling contamination within the dental unit, so here in this place. And then, of course, we have the oral cavity of the patient with the saliva, with the blood, with the biofilm, with the food debris, with restorative materials, and of course we have the airways and the pharynx. We have to know that not only in the sputum from the pharynx we find the viruses, but it is nowadays also suspected that the saliva is also containing the virus, not only because it gets there from the sputum, but also because the epithelium within the glandula can maybe also reproduce the virus. How does the aerosol get spread from the infected person? The aerosol is always produced, as we have heard, within the lungs, and within breathing the exhalation transports the aerosol up to 1.5 meters, and this is the reason why we are asked to keep a distance of 1.5 meters from the next person, at least in the public places. Coughing brings the aerosol up to 2 meters away, and sneezing is a process with really high velocity of 50 meters per second, so that the aerosol can reach a distance of 6 meters. And if we ask ourselves which microbes might be detected in the aerosol, there are some causative microbes, which means they can be the reason for some infection. And of course, in the working field of dental health care environment, we can find the bacteria that we may find in the mouth of the patient, but also in the water pipes like the Legionella species. So all these bacteria are exhaled with the aerosol from the patients, but also of course from the dental staff. And this investigation looked for these bacteria, and they also found fungi, but interestingly they did not find any viruses and no parasites, which should be questionable. Which instruments cause aerosol and which preventive measures can be taken when handling the aerosols? In prophylaxis, of course, we have these kinds of instruments like the ultrasonic instruments, the air scaler, and maybe also some laser instruments. The first and most important thing in the recommendations given by the European Federation of Periodontology is the patient triage that we have to make with our patients. And there are some questions that I'm now going to read to you so that you might keep them in mind, but of course you can ever go back to the presentation and look them up again. Do you, to your knowledge, currently have COVID-19? Have you previously been infected by SARS-CoV-2 virus? If yes, have you been declared healed from COVID-19 clinically or have tested negative with a nasopharyngeal swab? And this was what I was pointing out already earlier. We do not only find the viruses with a nasopharyngeal swab. It would be much less dangerous for the people taking the specimen if they just ask the patient to collect some saliva or some deep saliva. Do you currently have any of the following symptoms like fever, cough, respiratory difficulties, conjunctivitis, diarrhea, flu, lack of smell and taste? In the last month, have you had any of the following symptoms like fever, cough, respiratory difficulty, conjunctivitis, diarrhea, flu, lack of smell and taste? Did you have any contact with SARS-CoV-2 infected patients in the last month? Did you have any contact with subjects placed in quarantine, either self-imposed or organized by health authorities in the last month? Did you have any contact with subjects coming from highly epidemic regions in the last month? Are you a healthcare worker? If yes, what is your job? According to the patient's risk profile, assessment and his needs, the clinical agenda and the waiting list is organized. So if then the patient triage allows to give a date to the patient, and the patient arrives at the dental office. The temperature is registered with contactless thermometer. Other devices say that there is only low evidence or helpfulness of this temperature measurement, because if the patient is asymptomatic, he can still be a carrier of the coronavirus. Remove then the bags and the mobile and the coats from the patient, and then ask him or her to wash the hands with 60-degree warm water, which is 140 Fahrenheit, with soap of course, or hand rubbing with hydroalcoholic solution. Repeat in-office triage, and if the triage is okay, patients may take the seat, leaving at least 1 to 2 meters distance between each other. You may also think about always having just one patient in your practice for the time of COVID-19. Put on shoe covers before going to treatment, and then we look at the clinical stuff preparation. It's also 60-degree hand washing with soap or hand rubbing with hydroalcoholic solution. Put on the gloves and then put on the gown or a jumpsuit, put on the cap, put on FFP2 or FFP3 mask without valve or with valve, and if you use it with valve, you need an additional surgical mask. Then put on the goggles and the shield, and then put on a second pair of gloves. On this picture you can see one of our former students from the Dental Hygiene and Prevention Management Study Program, and she's working in southern Germany, and she and her boss have decided that in case they are going to create aerosol, she will need such kind of high standard personal protection equipment. And we can see she's making quite an happy face, but we can also see there is some climate up there. So if we now ask, is there any evidence for one or the other measure? There is very little high-quality peer-reviewed evidence, such as systemic reviews, meta-analysis or randomized controlled trials, either to support or to contradict some of our recommendations. There is no shortage, nevertheless, of opinion being expressed in print, along with studies that lack the rigor of peer review. Such poorly founded evidence can spread quickly without much challenge, and this was uttered by the College of General Dentistry and the FGDP from England. And there is a further utterance which says it is important to be wary of any claim of evidence for one approach or another, particularly when the outcome is associated with a specific risk that might be catastrophic. Every day we learn more about COVID-19, but all evidence needs to be clearly and carefully appraised before it is relied upon. So before the patient treatment starts, the patient should rinse with 1% hydrogen peroxide and 0.2% chlorhexidine digluconate each for 1 minute. So why 1% hydrogen peroxide? There was a publication from Kapf et al. Early in March of this year, and because we cannot really read what is written here, I have highlighted the positions that are interesting for us. And it is about the inactivation of coronaviruses by different types of biocidal agents in suspension tests. So we have to point out it is not about COVID-19 or SARS-CoV-2. It is about other coronaviruses from the past. And there ethanol has been shown to be very effective in lowering the concentration of the bacteria. And chlorhexidine was interestingly used in a very low concentration. We have to keep in mind it's tenfold lower than the concentration that we are normally using for the mucosa disinfection, and there it was proved on surfaces that it was not effective enough. Sodium hypochlorite has been shown to be pretty effective, and also hydrogen peroxide in a concentration of 0.5%. Again, to keep in mind, it was on surfaces and not on the mucosa. So why do we use 1% on the mucosa? We use 1% on the mucosa because, of course, we have the saliva within the mouse, so that the concentration is lowered by the saliva in the mouse. There has been criticism on the use of hydrogen peroxide because, first of all, the taste is not very nice, and it is also in discussion that it might play a role in cancerogenesis. But as we are not going to give the instruction to use it every day, and we are only using it in the practice, I think we can take the risk in the relation to COVID-19 transmission. And there is another effective disinfectant. It's povidone iodine in a concentration between 0.23 and 1%. It has been included in the WHO list of essential medicines, and it has a high potency for virucidal activity. It has outstanding safety and tolerability, and PVP iodine mouthwashes and gargles significantly reduce viral load in the oral cavity and the oropharynx. So, additionally to the mouse rinsing, we should, if possible, avoid aerosol. Possibly we should use decontaminating spray cooling, and I can tell you that the devices provided by W&H, they can be driven with 1% hydrogen peroxide and chlorhexidine. Use high power suction. This is a very important point, and we are going back to that later. And if aerosol production is inevitable, at least try to limit it. Possibly use patient aerosol shields, such as this one. There are some shields have appeared on the market, and we have to say what we have just heard. Nowadays there is still no evidence for the use of such shields. After treatment, ventilation with the open windows is very important, and draft would even be better. So if you have opposing windows in your dental treatment room, open them both. Environment disinfection with sodium hypochlorite, hydrogen peroxide and alcohol should be then carried out. So the staff after the treatment removes the gloves and the gown, removes goggles and shields, removes the masks, removes the cap and the gloves, and then hand washing again with soap and 60 degrees Celsius water, or hand rubbing with hydroalcoholic solution. What are other aerosol creating treatment procedures in dentistry on the whole? So of course it's tooth preparation or removal of restoration using high-speed rotating burrs with water cooling, especially with turbines. And if you are using such devices, please only use handpieces with anti-retraction valves. Then there is the multifunctional syringe, and of course, as we have already mentioned, the air scaler and ultrasonic instruments, and air polishing, and last but not least, the dental laser water cooling. So concerning the personal protective equipment, PPE is the abbreviation, we should reduce the microbial load within the aerosol, antiseptic mouthwash before treatment, antiseptic agent with the cooling media, using rubber dam, tooth surface disinfection, correct processing, periodic dental unit water system maintenance, and for the aerosol reduction we should use an effective suction technique. That means suction with a suction volume of minimum 300 liters per minute, and the suction cannula with a sufficient diameter of 12 millimeters, probably for hand dentistry, perhaps not only probably. The instrument use according to the indication, and ventilation of the treatment cabinet, open windows for 5 minutes. Concerning the suction technique, I have some pictures here that my colleague Peter Hana has taken in his practice, and we see here that the suction, the high volume suction, should be very close to the source of the aerosol, but not too close to the source. There should be always the tooth in between the tip and the suction device, such as we can see it here also in the lower front and in a little higher magnification here again. So keep close contact but not too close, because the water is needed for cooling the instruments. Concerning the question what irrigation should be used before treatment, there was a comparison done by Reddy et al. In the year 2012, and there was a comparison between water, chlorhexidine, and chlorhexidine warmed up to 45 degrees Celsius. And the colony forming units were measured, as we can see here. This is pre-treatment, post-treatment with water, pre-treatment, post-treatment with chlorhexidine, and we can see that we can get a little bit more effectiveness if we heat up the chlorhexidine to 45 degrees. So that we can say chlorhexidine heating to 45 degrees could be a measure to make pre-procedural rinsing more effective. And then the question may be perhaps also use herbal extracts. Again, a comparison between chlorhexidine, herbal extracts and water. And what we can clearly see, no matter what area, whether it's the doctor's chest or the patient chest or the assistant chest, we always get the best results with chlorhexidine in comparison to either water or herbal extracts which lay in between. So we can say pre-procedural chlorhexidine irrigation before ultrasonic scaling has shown to be more effective than herbal extracts or water in reducing the CFU, the colony forming units. So this publication was comparing the air scaler to piezoelectric ultrasonic scalers, such as the Vector and the Tigon. And we can see here the devices like the Vectron, the Tigon and the air scaler, and here are the devices that were used for the suction. In comparison here we have the high volume suction with a standard suction cannula, or the conventional saliva ejector that is mostly used by the prophylactic assistants or the dental hygienists. And there was a comparison between supra and subgingival instrumentation. And what we can see here is that in the supragingival instrumentation we have more aerosol creating process than in the subgingival, and we see here that the air scaler is producing the highest amount of aerosol. So we can say highest contamination with the air scaler, highest contamination when using the saliva ejector, and the best results in the combination of piezoelectric devices and high volume suction, and we could of course additionally use the saliva ejector. Another fact is playing quite an interesting role. It's the position of the treatment person in relation to the patient. And what was seen again here, this is the sputtering of the aerosol around the patient, and what we can see is that again the air scalar is creating the most intensive aerosol, and there is a slight differentiation according to the treatment guide position. And we can see here that the highest contamination is achieved when the treatment person is in the 12 o'clock position. So we may say less spatter when using piezoelectric devices instead of air scalars, and when using high volume suction, and the treatment position between 8 and 10 o'clock. Let's come to the next question. Which alternative treatment options, such as hand instrumentation and rotary polishing, are favorable? There is a new guideline from the EFP concerning the treatment of periodontitis in stage 1 up to 3, and it was recommended that supragingival professional mechanical plaque removal and control of retentive factors as part of the first step of therapy is mandative. So there is nothing said about how to do it. And in the active treatment phase, when it comes to subgingival instrumentation, it was the recommendation that it could either be performed with hand or powered instruments, either alone or in combination, so that we can say in times of corona we could favor hand instrumentation. For the maintenance phase, it was in principle the same as for the starting phase. There was no favoring of any method for biofilm removal. So, coming back to polishing, what actually is polishing? And do we really polish the teeth when we say that we are polishing? Polishing actually means smoothing the surface, and surface refinement by molecular surface agglomeration, which is achieved with high speed and high heat. And the pulp can only withstand 2.2 degrees Celsius, which means 4 degrees Fahrenheit temperature rise without damage, which we already know since 1965. So when we are talking about polishing, it means something completely different from when a dental technician is talking about polish. So what are we actually doing when we are polishing? We are leaving a layer of prophylaxis paste on the enamel surface, filling up the grooves that there are naturally or have been generated by tooth wear. So a thin layer of the prophylaxis paste is left on the tooth, and this gives the patient the feeling of a smoothened surface. In order to answer the question whether continuous polishing for many years leads to enamel loss, this interesting experimental setting has been developed by Pence et al., and it was reported in 2011. So they were using a handpiece with 2,500 rounds per minute with a pressure of 150 gram for 5 seconds for every tooth surface. I would say that 1,500 rounds per minute is a little bit quick, but nevertheless, 5 seconds of polishing time, 50 times on the buccal surface to imitate or simulate a semi-annual polishing in a 70-year-old patient that got the diagnosis of periodontitis in the age of 50. So 16 premolars, extracted premolars were used, and 32 third molars were used, and yes, there was a significant difference between test and control. Test meaning that no polishing was performed, and it was significant with P lower than 0.05, and the standard error of 6.25 micrometers was attributed to the 7 micrometer limitation of the measurement accuracy. So the mean difference for the treatment was in the end 20 micrometers loss of enamel. In relation to that, minimal enamel thickness at 0.1 millimeter coronal to the cementum enamel junction is 81 micrometers. So we can say in relation to that, going to professional tooth cleaning for 25 years, twice a year, leads to 20 micrometers of enamel loss. So there is no danger of exposing dentin by polishing. This is a little bit different in the situation of restorative materials. Here we can see a surface right after polishing with coated flexible discs, and this is the situation after 30 seconds of polishing with Nupro. And if you want to do it even more rigid, you can use a soft brush afterwards and even worsen the outcome. So please don't polish on restorative materials. What we are aiming at is biofilm destruction. In times of corona, rotary polishing can or should be favored. And here we get some help from W&H with the Proxio twist latch short polishing system. We can see here immediately that we have a completely different or smaller construction height than we used to have it with normal handpieces. And we can see it here in the direct comparison intraorally that it is much more comfortable when we are using this short latch polishing system. Additionally, we have to say that the sharp edge here, because it is not directly connected to the head of the handpiece, may lead to soft tissue injury. And we get even more freedom if we use the cordless system, providing more flexibility as well as in case of the foot control as in referral to the handpiece. So let's say something about the rubber cups. We see that there is a specific surface alteration and some lamella inside that are providing the opportunity that the prophylaxis paste is really tied to the rubber cup, and thus we can clean the tooth surface within 5 seconds with a rotation of 800 rounds per minute effectively without spreading the prophylaxis paste. So why should we still use prophylaxis pastes? Of course, because of the ingredients. Different stannous junctions against halitosis, caries, gingivitis and hypersensibilities. Chlorhexidine against bacterial recolonization. Different enamel strengthening and antibacterial fluoride connections. And formulations based on casein, minerals and arginine are helpful in caries erosion and hypersensibility prophylaxis. So please continue with prophylaxis. Our patients are not in our practice 363 days a year, so it's decisive what they do at home all the time. And do not do demonstration on the model. It has been proved, there is evidence, it does not help the patient. The only thing that helps the patient is that you demonstrate it in his mouth and that the patient has the chance to imitate it in front of you. So let's come to the last question. What is the new normal in the dental practice after Corona or within Corona? So if we come back to the first question, aerosol and prophylaxis, a danger for the dental team. Apply patient triage. That is one of the most important things. Oral health is a decisive factor in keeping systemic health, preventing from any kind of infection. Therefore, dental prophylaxis is still inevitable. Stick to the standard health precautions as we in our dental profession are utmost used to and have proven to be very effective. Stick to your national and regional precaution instructions. Use pre-procedural rinsing with 1% hydrogen peroxide and 0.2 chlorhexidine or povidone iodine. CHX warming up to 45 degrees has proven to be more effective in reducing colony-forming units caused by the aerosol. Use high volume suction with an effective technique and avoid aerosol creating procedures. Favor scaling and rotary polishing. Use high standard precautions in case of questionability of COVID-19 infection, as you have seen on the picture of our former student. We have a competent scientific research system providing new helpful instructions. Get informed and stick to them apart from the instructions given in this presentation due to the present available knowledge. So thank you very much for your interest, and now I am open for your questions. In the end of the presentation you find all the literature that has been mentioned in the presentation. I'm now going to the chat in order to see what questions have been raised. From Australia, very interesting, from Mexico, Tijuana, hello, good morning, from Chile. So, very nice greetings, but up to now not so many questions. So maybe I go back to the final points and I can say something more about it. We have heard that temperature measurement is obligatory at the moment, but of course if the patient is already infected but does not show any signs of infection, we cannot detect such a person via temperature measurement. Yes, the aerosols can float on the air. This is what we have seen on the picture that I took from Fromm and Strange. There you could see that the aerosol, even when we are just breathing, is spread in the air 1.5 millimeters, and of course, yes, it can spread from the patient's mouth even more if we are using aerosol creating procedures. Is there a place where we can see the presentation again? You came only at the end. Yes, there will be the possibility to watch the movie again. It will be on the homepage of W&H, so that you can watch it again there. And there also you will have the opportunity to post some questions, and they will be answered either by the members of the W&H company, or they will transmit the questions to me, and I will also take a look at at the site from time to time, that you can be sure that you will get answers. If so, can they remain within the room after the procedure? Yes, the aerosol of course stays in the room, but it will leave the room if you open the windows. That's why I pointed out that it is very important to open the windows after every patient. I have been working in Switzerland for 1 year, and this is already back in 2013, and I remember that already then we were opening the windows after every patient in order to get rid of the aerosol because it may contain bacteria, and we don't know which bacteria because we are not testing the bacteria after every patient. What is your opinion on the use of low concentration hydrogen peroxide as a substitute for H2O, for water? Yes, I mentioned that low percent of hydrogen peroxide is feasible for the use with the W&H instruments. So if you want to put 1% hydrogen peroxide into the water cup of the system, you can really do so. But you have to prepare the patient, because a lot of patients do not like the taste of H2O at all. So I think it's a very point to inform the patient before you are letting them rinse with H2O, with hydrogen peroxide, because they will think that they get something that will put harm on them, because the taste is really disgusting. Maybe there shortly will appear some preparation on the market. I think there is already a preparation on the market with 1% hydrogen peroxide and mixtured with chlorhexidine. But if you yourself don't mixture it, because then you lower the concentration of both preparations. I use after extra ozone producing in the practice I just came to use. Yes, ozone is also effective in disinfection, but as we have heard, there are a lot of recommendations on the web, but there is low evidence so that we should take any kind of precaution we think that we should do until we have the evidence that either we do not need it, or yes, it was good that we are doing so. What about the use of hypochlorous acid inside the irrigation system? I think you should stick to the products that are provided by the dental unit producers, because I cannot say anything about using hypochlorite in the dental unit. If patient needs periodontal surgery, osseous contouring for crown lengthening, what extra precautions do you take? I think this is really a procedure that is connected with high aerosol production. If you use ultrasonic instruments, you may also use, for instance, the scalpel to reduce the bone around the tooth. This is how I'm always doing it. I'm not using rotary devices, and I'm not using ultrasonic devices to do crown lengthening, especially not in the time of COVID-19. So try to reduce aerosol producing procedures within this time, and if you just do the surgery and you have good suction and you do the crown lengthening with a scalpel, you are not going to be in danger of disease transmission if the patient is COVID-19 positive. What is the best method to disinfect the air if there are no windows in the box? Well, then you have to stick to some mechanical devices. You cannot just spray some disinfection into the air and think that you are going to decontaminate the air with that. You really need professional air suction instruments to place it in your cabinet if you want to continue working in such a place. Regarding the type of handpiece to be used, can you tell us more about the proper to be used? Does W&H have those? Yes, the W&H company has these devices with the this anti-resuction valve, so that the water is not resucted or re-aspirated into the handpiece. But this is nowadays normal technique. If you buy new instruments nowadays, all the instruments have this technique because of all the other diseases that may be transmitted in the dental office. It's not the first time that we are talking about a dental disease transmission in the dental office. I remember very well the situation of HIV. That was when I was studying, and we were, I remember, very afraid of HIV also in the dental field, and that was the time when these control valves started to be installed in the handpieces. What is your opinion about devices such as extraoral suction? Are they functioning? With this point we come back to these patient shields. They are sometimes also combined with extraoral suctions, and we are not we do not spend enough time already with all these questions that we have to say that there is no real scientific evidence to make the one or the other recommendation. But if you have the opportunity to install something like that in your practice, I would not say don't do it. As I don't say don't do it if you want to use high standard personal protection equipment. UV light is a good idea for clinic. I have read about this ultraviolet light disinfection, but it seems that it does not work with COVID-19. There was a recommendation, I have read about it, but then I have read a comment on this article in which high evidence on the base of a lot of experience was proclaimed, and then there was a comment in another journal that this kind of evidence is not really scientific evidence, and that therefore we cannot really recommend UV ultraviolet light. But I would again say, if you have this equipment in your practice, keep on using, because we are not only talking about COVID-19, we are also talking about other infection transmission still in the dental office. But on the other hand, we have to say that we have really proved in our profession that we have a very high standard in hygiene. If you look at other other professions in the healthcare system. People do not always wear mouth and nose covers, they do not wear gloves, they do not wear clinical wear if you look into the private practices. For your opinion, is the electric motor can reduce aerosol more than air motor? Yes, the turbine creates less. The turbine creates more aerosol, but I think it is not so much a question of creating more or less. It should be a question that if you create aerosol, then you should use sufficient suction. And probably further protection devices such as shields, either for the treatment person or for the patient or around the patient. Is the ultrasonic device equally dangerous as the high-speed handpiece in terms of transmission of COVID-19? I would say yes. As I've now mentioned, it's not so much the question with which device you are going to create the aerosol. It's more the question what effectiveness you have in your suction and in other devices to be protective, to protect yourself and to protect your dental assistant. Sorry for making an interruption. I'm looking for the next question. So let me say something about dental prophylaxis in these times. We should not stick back. From prophylaxis in these times of COVID-19, because we have seen that dental health and oral health is very important. It is the opening through which the viruses come into our body, and if we have a good oral health situation, this may also protect against the virus infection. This has always been like this. Oral health has always been important for systemic health, not only in the last 25 years, but we have had knowledge about that much earlier. But nowadays, of course, we have this knowledge on a much higher level of evidence. So we should not step back from prophylaxis, but we should have in our mind that we also need protection, and that was the reason why I was telling you step back from aerosol creating procedures if it is possible. Use hand instrumentation in the times of COVID-19. It will not last forever, and of course the other polishing systems like air polishing have an absolute indication in maintenance therapy, and but in the times of COVID-19 I would like to give the advice that you get back to rotary polishing and hand instrumentation. So thank you very much for the many greetings that I got from over the world. It was a pleasure for me to be here with you today. It was very, very exciting for me. Maybe you have perceived it one or the other, but it was also very much fun to be with you this evening or afternoon, and I like very much your questions and the greetings from all over the world. Thank you. Bye-bye.